Okay, no problem. You can speak up.
అక్కడ అవసరం లేదు ఇక్కడ ఆడియన్స్ వినిపించాలంటే ఇక్కడ అట్లీస్ట్ ఇది బయట
Start.
So good afternoon, everybody. Good afternoon, friends, and good afternoon, Dr. Mulibadwa sir, to give me an opportunity to present in this forum. And actually, I have been a student of Mulibadwa sir about way back in 2005. So I have completed my MD and DM, and now I'm here to, under his supervision, we are presenting one interesting case in this forum. So basically, we know about SLE, systemic lupus erythematosus, and how severe the problem is. And we come across these cases commonly. And here we see a lot of young females suffering with a condition called SLE, and how they are having problems, and how we're tackling the cases will be dealt in this session today. So basically, to start off with, we had a 17-year-old female. 3 months back, she came to us in the month of June with complaints of pedal edema, and which was progressing to anasarca. She specifically complained of froth in urine, and she had hypertension. Edema has been progressing since 15 days. By the time she came, the edema was progressing, and she had full-blown anasarca. And so we found out some other history also with her, like whether she had any fever, she had used any analgesics or any other things, whether she was having decreased urine output. Nothing of that sort was found. And she didn't have any of the similar history in the past. With this in mind, we took further on. They said that she was apparently normal a month ago with no other complaints, no other medications, and she didn't have any family history. She didn't have any joint pains, rash in the past. She had regular menstrual cycles since about 12 years of age. On examination, her pulse and respiratory and other things are fine. She was hypertensive. Her blood pressure was 150 or 80. She had pedal edema and abdominal distension. She had no any other findings like joint swellings or rash on the body. Her lungs were clear, and she had ascites on abdominal examination. This is just a gist of the present of examination findings when we looked into her. So with this in mind, that patient is having anasarca and edema and pedal edema. She was definitely having protein loss, that is through the evidence of urine. She was having froth in urine, and she was hypertensive. With this in mind, what would be the clinical diagnosis which one would think of? This slide will tell. So suppose someone has proteinuria and edema, we think of a nephrotic syndrome. In this girl, she had proteinuria and edema. Along with that, she was hypertensive, and other findings like she didn't tell about any hematuria, but she was hypertensive definitely. So this syndrome, or what diagnosis we generally keep, is called a nephrotic syndrome. It overlaps. It's neither completely nephrotic, since she was hypertensive, and she definitely had hematuria. In this coming slides, you will see that. So this is an overlapping syndrome called nephrotic syndrome. We got on the labs. These are investigations we had presentation what we had. She had a hemoglobin she was anemic, hemoglobin 9.5. Her creatinine was 0.9, that's normal. She had hypoalbuminemia. Definitely protein loss was contributing to hypoalbuminemia, 1.8 grams per deciliter. And she was having hypercholesteremia, 238 grams of total cholesterol. Her thyroid was normal, and urine had +4 protein albumin, and she had 6 to 8 RBCs in urine. So definitely she was having hematuria. We did a urine protein creatinine ratio that was showing about 2.8 grams of protein loss in 24 hours. We got an ultrasound done, which showed normal size kidneys. So basically, we are dealing with a nephrotic syndrome. And once we see this kind of presentation, we ask for a kidney biopsy. So one would ask me, did we get any other test? Some other tests are like collagen profile, ANA, dsDNA, complement C3C4. We generally ask for these tests when we see what they call a nephrotic syndrome. But basically, the finances were a constraint, so that A single biopsy can give you entire information of the patient. So at times we consider, we keep in mind other things, and we ask for his kidney biopsy. That is a single point investigation which can reveal everything what is happening for the patient. So this is a kidney biopsy. Kidney biopsy showed a proliferative glomerulopathy and with a prominent wire loop lesions, hyaline thrombi, and a full house immune deposit suggestive of class 4 lupus nephritis with activity. This is a full house. Full house in the sense all the complements, all the immunoglobulins, IgG, IgM, IgA, C3, C1q, kappa, lambda, everything is positive. This is called a full house, what you call immunofluorescence microscopy. This is classical of SLE or lupus that we usually see. When we learn in your undergraduate and post-graduation, we get to know, we have this important thing which comes up regularly. So we'll break the discussion, we'll break the case there, and we'll go with the discussion. So what is SLE? SLE is a it's an autoimmune condition which is diagnosed by certain criteria. These are the criteria. This is commonly seen: mala rash, discoid rash, photosensitivity, oral ulcers. Systemic criteria like arthritis, that is joint pains, serositis involving pleuritis or pericarditis. Renal disorder. In renal disorder, a patient should have a persistent proteinuria of more than 0.5 grams a day or +3 proteinuria in a CUE sample. And one more criteria is RBC cast or tubular, granular tubular, mixed cast. So this is a renal criteria we generally look for. Other criteria can be neurological disorders present with seizures or psychosis, hematological present with hemolytic anemia, leukopenia, lymphopenia, thrombocytopenia. In immunological, in investigations, we look for dsDNA, anti-Smith antibody, a positive ANA with anticardiolipin antibodies, and other positive tests like lupus anticoagulant are also contributory, or they can be a diagnostic at times. So one more thing we look for is ANA antibodies. So once we diagnose lupus, here we are dealing with the lupus nephritis, class 4 lupus nephritis. These are different classes of lupus nephritis. Class 1 is minimal mesangial lupus nephritis. Class 2 is mesangial proliferative. Class 3 is focal. And class 4 is diffuse lupus. Here we are dealing with the class 4 or diffuse lupus nephritis. Class 5 is membranous, and class 6 is advanced sclerosing. This falls into CKD. All these things actually depict the severity of the problem. Class 1 behaves like a minimal change disease with nephrotic syndrome, where the immunosuppression or treatment is very mild. When we go to class 3 onwards, class 4, we go for full-fledged immunological, agents like steroids and cyclophosphamide or other medications. Class 5 and class 5 is treated as we treat as a membranous nephropathy with little bit of difference, and class 4 is taken as CKD. What are the treatments we generally give? When we see a case of lupus with class 4 here, we pulse the patient with steroids. We give them 1 gram, 500 milligrams to 1 gram of steroids daily for 3 doses, followed by 0.5 to 1 milligram per kg body weight. Maximum dose allowed is 60 mg is the maximum dose, or 40 mg depending on the weight. That is initial pulse given for class 4 lupus and with the activity or with severe activity or present glomerulonephritis. After initial immunosuppression with pulse steroids, we go on for cyclophosphamide. At this point, I would like to tell about 2 regimens which are normally accepted. One is NIH protocol, that is National Institute of Health protocol, where they give about 1 gram of per meter square of cyclophosphamide in 6 doses. Other regimen is Eurolupus regimen, where the doses is reduced to 500 milligrams every 2 weeks for 6 weeks. So when we give higher doses, the cumulative dose of cyclophosphamide goes up to 9 to 12 grams at times. In Eurolupus, total immunosuppression is limited to 3 grams. So the risk of ovarian failure, that is generally we have to consider, malignancy, everything or complications comes down when we use Eurolupus regimen, where we give 500 milligrams every 2 weeks for 6 doses. Cyclophosphamide itself is not suitable for most patients. Generally, we see a young lady here. So generally, when we ask for a patient, young lady, we counsel them that the chance of premature ovarian failure, whether you're willing to take this drug, only then, after the consent of the patient attenders, only then we initiate cyclophosphamide. We can either ways we can give induce with mycophenolate also 2 to 3 grams orally for 6 months also is also advisable nowadays, but mycophenolate generally is given for milder patients or patients with milder disease. It is not suitable for severe lupus or severe class 4 with crescents and other things. Maintenance can be either with mycophenolate or azathioprine. Adjunctive therapy of hydrochloride is advised or offered for all the patients. This is a classical, treatment regimens which are generally followed for all lupus patients with lupus nephritis. In this case, we pulsed the patient with 1 gram on day 1, methylprednisolone, 500 on day 2 and day 3, and is given for 3 consecutive days. Maintenance therapy was given mycophenolate, twice a day. We don't go for higher doses because in India, higher dose of mycophenolate we have seen through our experiences they don't tolerate. 1.5 is a dose. Actually, she was around 38 kgs. That was okay for her. We kept her on 20 mg steroids initially, and then onwards. Initially, she had a lot of symptoms like anasarca, and she was having ascites that was compromising her breathing and other things. So we gave her injection albumin along with Lasix. Other treatments like Lacidin, atorvastatin also started. Even after initially she settled down, symptomatically she was better. She was discharged. She reviewed twice in the interval of 1 month. She persisted or she continued to have this pedal edema and an ascites and anasarca, and it was really bothering her. She visited often in a month span. She visited us twice. They're basically from peripheral place. So in the middle, after 1 month, she had developed leukopenia and anemia also. And for that, her hemoglobin dropped around to 6 grams. So we had to transfuse her also. And then we reduced for some time. We totally stopped mycophenolate because that can cause anemia and leukopenia. We had to stop it for some time. And after that, we reduced the dose of mycophenolate. And what we found was this mycophenolate was not helping her. The patients were offered cyclophosphamide. We were told that she's young, there's a chance of ovarian failure, so they denied using. They didn't want cyclophosphamide, so mycophenolate was a choice. So we gave that. It was not working for her. So what is response? So these are criteria for response. So suppose a decline in protein creatinine ratio of less than if it's coming down to 0.5 grams per and of 24 hours urine protein. And return of serum creatinine to previous baseline, that is called complete response. If it is more than 50% decrease, it is called partial response. Nothing is achieved, it's called no response. These are different criteria according to different guidelines, KDIGO, ACR, and European guidelines and Dutch guidelines. So what do the protocols say? If the patient is having severe lupus, the choice will be to pulse them and always advise them to go for cyclophosphamide. If they are not willing, what we can do is other regimens which are allowed, that is rituximab. So here again we labeled her as resistant lupus or non-responsive lupus. Treatment options, we again told them that you can go for cyclophosphamide, but infertility is always explained to you. And other things is rituximab. We can go for multi-target regimen also, but rather than that, we offered them a rituximab, which is because the response rituximab is good nowadays. So this is a regimen which is offered to her. Rituximab was given. So what happened? She received 2 doses, 1 gram each at 2 weeks intervals, rituximab. At the end of second dose, she started responding. Clinically, NSRK decreased significantly. That was very evident for her. She felt very comfortable. Proteinuria, she had partial response. She didn't get complete response. According to the criteria, she got partial response. Albumin levels also increased, and she was feeling much better. She was well for a couple of weeks in the follow-up. She was doing well for a couple of weeks. NSRK disappeared, and she was doing well. Suddenly, after 2 weeks, she started developing. She threw a fit in the house. So she's brought again back to Hyderabad, and there we saw other causes of seizures, like whether we ruled out stroke, we ruled out hypoglycemia, hypocalcemia, everything we ruled out, and it was diagnosed as CNS lupus with CNS involvement. At the same time, she had pancytopenia, the sense she had She had leukopenia and she had anemia and she had low platelet count. Then we diagnosed hematological involvement also was there. A rheumatologist also consulted. Symptomatic treatment, she received transfusions, she received anti-epileptics and other things. And after that, with the consultation of a rheumatologist, we pulsed her again. We gave a second pulse after 1.5 months. With this time with 2 grams of methylprednisolone again. She recovered from the initial phase of seizures and pancytopenia, and she was better for next 10 days. After that, bad for her, she again developed a nephrotic flare. So when the nephrotic flare, again she started having, initially the edema was minimal, again it progressed on to full-blown anasarca. And when this happened, we advised her for a second kidney biopsy. That's the protocol we do. They were not willing because of both for finances and they'd spent a lot. And so at the same time, we wanted to know whether our ANA, how were the ANA titers? ANA titers were very high, around 800 ANA titers were there. So we offered her this therapy called plasma exchange. Plasma exchange, the evidence of plasma exchange therapy in lupus is not so strong, but it can be used temporarily for time being to buy time for till the other medicines work. So plasmapheresis was given to her. It can remove autoantibodies, complement immune complexes, and other molecules, and so it's very useful in at least temporarily in lupus in these patients. But according to plasmapheresis criteria, the guidelines criteria, this is not a Cat1 indication for lupus. This is means like category 2 or category 3 indication. These are the basic, initial, strong indications are Guillain-Barré, good patch, and other things. In lupus, we can use it when the patient has TTP and when the patient has anti-ANCA, when the patient has antiphospholipid syndrome. And these are 2 indications in lupus where we use. We can use in other conditions also. In lupus nephritis, also 1B indication is given there. The response is very short interval, and we have to look for other medicines till we can only tide over the present condition. We have to look for other medicines to give a better result for her. So this is a loop. She received 4 exchanges. Ideally, textbook says it we can give her to 7 exchanges. Within after first exchange itself, she started responding. Second exchange, she was much better. And we reuse the filters also. There's a plasma filter we use generally. For 2 sessions, and at the protocol in our institute, we use the filters. So this is first session where she received. And now in the follow-up, she's in complete remission as of now. And she has developed myelin dysfunction. After this, we started on multi-target therapy that we introduced tacrolimus also. Now she's on mycophenolate, tacrolimus, and prednisolone. Hope this approach works because plasmapheresis, she has still the line in situ, central line or dialysis catheter in situ, so that if she requires some more sessions of plasma exchange, we can do it. We are just buying time so that this regimen works for her and she comes out of the lupus or she goes into remission. So take home message in today's session is, first of all, lupus diagnosis. It's simple nowadays, means like we have all the criteria placed. We need a 4 out of 11 criteria to diagnose it according to the ACA criteria. She presented with as a nephritic syndrome. And from then onwards, we did a biopsy and we could diagnose as class 4 lupus. So we didn't require other ancillary tests for that. See, prognosis, younger patients with hypertension, patients with male patients don't do very well in lupus, especially class 4. They develop a lot of their response to treatment might be poor, as you are seeing in this case. We had tough time treating her. Initial response was not there with after pulse steroids, nothing worked for her. We had to resort to rituximab. That also showed some temporary response, partial response. Again, we had to resort to plasma exchange. That is working for her right now. Extra lupus flares can happen during any lupus for any lupus patients during the treatment. So we had dealt with the extra renal symptoms also, lupus also. We need to follow up the patient regularly, thoroughly, and then we have to keep them into confidence. So basically, these patients need a lot of counseling basically they have to understand this problem is going to stay with them like diabetes or any other problem. So they have to understand or inculcate in their mind that this problem will be there. They have to handle it. And these patients, even though they are from a village background, they understood the situation and they are thoroughly following with us, and they're getting treated with us. Thank you. Thank you for the opportunity, and thank you for the patient hearing.
So,
Yes.
wonderful case management, Dr. Pawan.
Thank you, sir.
Few questions. Like,
Yes.
What are the side effects of rituximab? Generally, if we compare with cyclophosphamide and
Yes,
others, is it having a lesser amount of adverse effect?
Yes, sir.
profile?
Yes, sir. Definitely. Actually, cyclophosphamide is highly toxic, sir. It is toxic in the sense long term and short term. Short term, what we see is like the patients can go into leukopenia, infections, especially cyclophosphamide. We have seen viral infections. We actually, we have presented elsewhere also herpes zoster infections, flaring up of herpes zoster infections, viral pneumonias is very common in cyclophosphamide treatments. And at times the leukopenia is so severe, requiring requiring stoppage of the medicine and other requiring antibiotics, and they get so sick at times. We had a patient, cyclophosphamide initiated for other reasons. She had a crescentic glomerulonephritis. She had severe sepsis. Took almost 15 days for her to recover. So cyclophosphamide immunosuppression is very severe cyclophosphamide, and during infusion also patients can have vomiting, nausea. They can have bladder cystitis, hematuria. So we used to give previously Mesna was available. Commonly used to give Mesna. Nowadays Mesna also is very tough to get. So we are not giving. We are hydrating the patient well and giving cyclophosphamide. That is one part. Immediate infusion risk, GI symptoms, bladder cystitis, hematuria, and next immediate would be infections and risk of sepsis and other things. Long term, cyclophosphamide cumulative toxicity in females can lead into ovarian failures, premature ovarian failure, and malignancy.
How about rituximab?
So rituximab actually is known to cause PMLs or malignancies in the long run. But sir, actually, compared to the results, actually nowadays we are seeing, we are not finding. We're using rituximab very much in all our patients actually. In transplants, also we're using for across ABO transplants. Almost all nephrotic syndromes nowadays are recommending rituximab. I'm not underplaying the what do you call risk of rituximab. Rituximab can cause PMLs, leukoencephalopathies, proliferative myeloencephalopathies. It can cause flaring of tuberculosis. It can cause malignancies in the long term and blood malignancy, blood dysplasias in the long run. But short term, it is doing a wonderful job. Nowadays, the primary line of treatment for membranous nephropathy is switched on from other medicines like cyclophosphamide, tacrolimus to completely to rituximab nowadays. So 2 pulses, almost 70 to 80% of patients membranous nephropathy are getting good response. So
last week I had a case of SLE, came from Vemulavada.
Okay,
so sir. She has all skin lesions. So I just sent her to the dermatologist for
Yes,
a review of the skin lesions.
Yes, sir.
So she didn't come back. So I mean, it happened 3 weeks ago. So after 3 weeks, she came back.
Yes,
then she had lesions, everything resolved. I said, have you consulted the dermatologist? Yes, sir. And she gave the prescription. It is having rituximab. I thought, oh my God, dermatologists are using left and right rituximab, whereas physicians, we are still depending on the subspecialty because rituximab is that way. Relatively toxicity profile is
less, very less.
How is it a very costly therapy?
Yes, it's a costly therapy. One vial costs around MRP. One vial charges around 37,000 to 49,000, sir. One vial, 500 mg. 2 vials are required. So total 4 doses, 2 lakhs.
Around 2 lakh therapy, 2 lakh rupees it will cost.
2 lakh rupees. Total therapy.
Cyclophosphamide?
Cyclophosphamide cheap side, it's around 3,000.
3,000
3,000
rupees.
rupees.
So, suppose if the patient has a affordability,
Yes,
do
sir.
you suggest to straight away start with rituximab instead of trying with the toxic cyclophosphamide and this?
Sir, I would like to keep rituximab as a reserve drug, sir. Let us not use rituximab, right away.
What is the reason?
Sir,
There is
rituximab,
nothing like a
nothing, sir, nothing, sir.
resistance or anything, right?
Nothing, no resistance, sir. Sir, basically, India is a poor country, and every time, sir, it's not that rituximab gives response. Again, these patients can again go into relapse. Again, that time also, again they'll require rituximab again. So that can happen. And one more thing is,
But
so we
relapse can
don't
happen even with
even with
cyclophosphamide.
cyclophosphamide. So we don't know the long-term impact of rituximab. Nowadays, the current phases, we're using rituximab left and right for everything, sir. For right from nephrotic
We are still
syndrome.
in honeymoon.
Yeah, sir. We don't know long-term after 3 to 5 years. We might be seeing many issues with rituximab. Like it is there, the drug is there in the market since a long time. Off late, since past 2 to 3 years, the usage has become very rampant. For even rheumatoid arthritis, everyone is using rheumatoid. They're using it commonly. They're using rituximab.
Correct.
Yes.
Thank you so much.
Thank
and,
you, sir. Thank you, sir.
For
We had
taking your
this.
time in
Yes.
spite of a busy clinical
Thank you,
hour.
sir. No
And
issues.
every week we planned at least 3 to 4 cases discussed so that we are treating patients at the same time. Patients are the best textbooks which make us learn, right?
Yes, sir.
So thank you very much.
Thank you, sir. Thank you for the
Now
opportunity.
I
Thank you,
present
sir.
the next speaker, a very passionate.
Thanks a lot, sir.
Yeah. So next, I present our next speaker, a very passionate clinical cardiologist, Dr. Syed,
Thanks a
who
lot,
is
sir.
MRCP, and today we have a lot to learn from on the various scenarios of the DVT in various clinical conditions. Now, Dr. Syed, please.
Thanks a lot, sir. Thanks a lot for Mr. Knight's introduction. So, are my slide visible? Hello, my slides are visible.
Yes, they are very much visible. Yes, Dr. Syed, you can start.
Yes. So, good evening, everybody. Today, my presentation's topic is DVT and pulmonary thromboembolism, and special approach to the DVT and PTE patient, that we should think beyond anticoagulation regarding these cases, and we should try to find out what is the reason behind DVT and pulmonary thromboembolism. So, I am not going to present any rare case here or any case which we don't encounter regularly in hospital. I believe that young doctor should be able to treat 90% of the diseases that he is encountering in the hospital in an excellent way, and few patient 5 to 10% that we have the specialist to treat that patient. But one should be expert in handling what we see regularly in hospital, and we should be able to find out and treat regular cases in an excellent way. let's start my presentation. This is a clinical scenario based approach. These are the cases that I have seen in my clinical practice while working in different hospitals. So this is a 55-year-old male patient. He was a police constable by profession. So I was in a care hospital emergency when I received a call regarding him that, sir,
Doctor, you
non-diabetic,
can, doctor, you can make it slideshow.
it is not coming, sir.
No, you can make it a slideshow. It is individual slides. No, above that you have the slideshow. Click on that.
Slides are changing, na, sir, now?
No, you did not go into the slideshow mode. You go up, up. You have the slideshow. No. Above that, you have file, home, insert. There.
Slideshow is coming, sir.
No, you have to.
మన దగ్గర ఉందా?
Sir has to stop share. Click on entire screen.
Share entire screen.
Yes, sir. Yes, sir.
While clicking entire screen, you have a option called as enable system audio also.
While you are sharing entire screen, you have a provision
To share the screen audio. System audio should I share, sir? Now is it okay, sir? Is it okay now, sir?
Yeah, please continue, doctor.
Yes. So, 55-year-old male patient, he was police constable by profession. He was non-diabetic, non-hypertensive, and he was recently diagnosed with pulmonary cox, and he was on anti-tuberculosis therapy since 5 months. But since 1 month, he complained that he was not feeling well and he was having malaise and lethargy. So he took leave from the police department and he was in home since 1 week, but he was not definitely bedridden. He was used to walk in his home and do his daily activity limited in his home. And suddenly, in one night, he developed overnight swelling of his left lower limb. His left lower limb was red and painful, and it was swollen. So he was brought to hospital, and vitals in hospital. His pulse was 86, respiratory was 14 per minute, blood pressure 120 by 80, saturation was 98% on room air, and his investigation revealed that his hemoglobin was 5.4 gram percent, TLC count was 9800, platelets 2.5 lakhs. ECG revealed sinus rhythm with no STT changes, while bedside 2D echo done in the emergency room revealed that normal size cardiac chambers, no LVR WMA, good LV systolic function, with ejection fraction of 65%, and his IVC was normal and collapsing. So basically, there was no evidence of pulmonary thromboembolism in him. And we did a lower limb venous Doppler, and we found that there was acute deep venous thrombosis of the left lower limb veins. So this was quite unusual why he developed DVT, and we thought to search for the cause of DVT. So this patient has suffered acute DVT of left lower limb. There were no signs of pulmonary thromboembolism, but there is no obvious precipitating cause of DVT. Like, he was not actually bedridden, he didn't had any fracture, he didn't underwent any hip surgery, and he was not having any critical illness, like he was not in ICU in a bed. But this patient was anemic with hemoglobin of 5.4 gram percent. Was that a clue for cause of DVT? So medical gastroenterologist was involved because he was having iron deficiency anemia, to find cause of anemia. So we did upper GI endoscopy, and you can see in upper GI endoscopy we found that he had a large gastric ulcer, and we took biopsy of that ulcer, and biopsy of that ulcer revealed that he actually had a gastric cancer. So this was the reason behind his DVT. The underlying malignancy was causing his blood to become hypercoagulable, and this hypercoagulable blood led to development of DVT in this patient. So the UK NICE guideline advocate that if you have any patient who is above 40 years of age and he's having DVT and there is no obvious precipitating cause of DVT like bedridden status or any fracture or any injury or any critical illness, then you should search for occult malignancy in those patients who are above 40 years of age. So take home message from this case is that DVT treatment is far beyond starting anticoagulation and putting patient on oral anticoagulation. DVT patient needs to be thoroughly evaluated to find cause of DVT. As in this case, occult malignancy was the cause. Common causes of DVT are immobilization, surgery, trauma, pregnancy, use of oral contraceptive pills or hormone replacement therapy in postmenopausal women, malignancy, antiphospholipid antibody syndrome in young ladies, heparin-induced thrombocytopenia, proliferative disorders, smoking, obesity, inflammatory bowel disease like ulcerative colitis, Crohn's disease. Although these patients have bloody diarrhea, but they are hypercoagulable, inflammatory bowel disease patients, pacemakers, central venous catheters, nephrotic syndromes. These are the causes. These we should search for these causes, and if we are able to treat this problem, then patient will not have recurrent DVT. Scenario 2 is 37-year-old lady. She was non-diabetic, non-hypertensive, and she went to Kedarnath Yatra in Kashmir, and she had road traffic accident there, and she had lots of faith on orthopedicians in Hyderabad. So she came all along from Kashmir to Hyderabad for surgery. So she was having. I was given consultation for fitness for non-cardiac surgery. She had excellent functional capacity before developing this fracture. Her echo ECG was fine, so I cleared her for surgery, and her surgery was uneventful. And she was put discharged on unfractionated heparin as a DVT prophylaxis, because at that time Clexane was costly, and the dabigatran was recently introduced, and we thought that it is better we give heparin as a DVT prophylaxis. And she was discharged in stable condition. And after 1 week, she came back to hospital, and I got a call that this lady has swollen limb, operated limb, and it was red and warm. So we showed to the surgeon, thinking is there is any infection at the fracture site, but the signs of infection were not there. TLC counts were normal, CRP was normal. So lower limb venous Doppler confirmed that DVT, and we were not sure. This lady is on unfractionated heparin. Why she developed deep venous thrombosis? So possibility of heparin-induced thrombocytopenia thrombosis was taken into consideration because she was exposed to heparin. So complete blood picture was sent, and it revealed thrombocytopenia. While we sent HIT antibodies, that is HIT antibodies, they came as positive in this patient. So in this patient, we stopped the heparin, and we treated this patient with fondoperinox. Later, her platelet count improved, DVT resolved. We initiated dabigatran as a anticoagulation protocol for her for 3 months, and this was the reason of DVT. Take home message is that if we are putting any patient on heparin, we should do daily CBP to see for platelet counts. If there is any unexplained thrombocytopenia, that can be marker of heparin induced thrombocytopenia, or in some patient heparin induced thrombocytopenia thrombosis also. And whenever HIT is diagnosed, we should use non-heparin anticoagulants like bivalirudin, ergotroban, fondoperinox, apixaban, rivaroxaban, dabigatran, danaparoid, and warfarin. And in India, we usually rampantly available is fondoperinox, apixaban, rivaroxaban, and dabigatran are easily available. Scenario 3 is 39-year-old male patient. He is non-diabetic, non-hypertensive. He suffered fracture neck of femur secondary to road traffic accident, and he was not that much financially strong. So in Hyderabad, they took patient to some local quack, and he told that if he apply these pattis and we keep him on bed for 25 days, he will be all right. But unfortunately, after 25 days, he tried to walk, but he was unable to walk. Pain was there. So now he realized that he needs to go to hospital. So he was brought to hospital for fracture fixation, and I was given consultation to clear this patient for surgery for hip surgery. So when I when this patient I saw, he was having right sided chest pain, he was breathless, and he was having complaint of palpitation since 3 days. His pulse was 117 beats per minute, blood pressure was 110 by 70, saturation was 92% on room air. ECG revealed sinus tachycardia with no STT changes, while echo revealed tachycardia during study, normal size cardiac chambers, no LVRWMA, and good LV systolic function. But something was wrong. This patient was having right-sided pleuritic chest pain, and he was breathless since the 3 days, and he was tachycardic. His SpO2 was 92%. So I saw his X-ray that was done in a surgical profile. I could see that there is right-sided opacity in the right base. So considering his unexplained tachycardia, tachypnea, saturation less than 94% on room air, and right-sided opacity in chest X-ray, he was prolonged bedridden for more than 25 days. We did D-dimer, it came as 4,500 nanogram per ml. So possibility of deep venous thrombosis leading to pulmonary thromboembolism was suspected, and bilateral lower limb venous Doppler as well as CT pulmonary angiogram was advised. And his CT pulmonary angiogram revealed that he had right-sided subsegmental pulmonary embolism along with pulmonary infarction. And this pulmonary infarction was responsible for his pleuritic chest pain, and pulmonary embolism were responsible for tachycardia and an unexplained hypoxia. And surprisingly, his left lower limb venous Doppler was negative for DVT, indicating that the whole of thrombus was embolized to the lungs. So management of this patient, as he was not vitally stable, so his surgery was deferred in view of DVT and pulmonary thromboembolism. This patient has to undergo surgery. That's why he has to be started on parenteral anticoagulation. So I started him on injection Clexane 60 mg BD as a treatment dose for pulmonary embolism. And as the Clexane started to act, his symptoms of chest pain resolved and tachycardia got settled. His saturation improved to 96% on room air. And after around 4 to 5 days of anticoagulation, his heart rate stabilized and his saturation improved, and he was symptomatically better. So I cleared this patient with high risk for surgery, and fortunately he underwent surgery, and it was all well. After surgery, I put this patient on Eliquis 10 mg BD for 7 days, followed by 5 mg BD for 3 months as a anticoagulation for unprovoked DVT due to bedridden status. So, learning points in this case is that early we fix the fracture, early ambulate the patient, chances of DVT and pulmonary embolism we reduce. Pulmonary thromboembolism can present as pleuritic chest pain too without hemodynamically instability. Clue can be unexplained sinus tachycardia only. The typical ECG that we say S1Q3T3 is present in only 24% of cases. Most common finding in pulmonary embolism is sinus tachycardia. Absence of DVT in Doppler is not a proof that there is no pulmonary thromboembolism, because many times whole thrombus that have formed at the lower limb can get embolic to the pulmonary artery, causing pulmonary embolism. And 2D echo becomes abnormal only in hemodynamically significant pulmonary thromboembolism. Small PTE, there will not be any 2D echo change. So 2D echo is not a test that will rule out pulmonary thromboembolism. Your well score, your clinical suspicion, your vitals, all you have to consider to diagnose pulmonary thromboembolism. Immobility in a healthy patient can too lead to DVT in absence of medical comorbidities, even if it is as less as 3 days. In guidelines, it is said that if patient is immobile for even for 3 days without anticoagulation, he is a candidate to lower limb Doppler and D-dimer test, because immobility of 3 days also without any comorbidities in a young healthy patient can also lead to formation of DVT. Scenario 4, 64-year-old male patient, hypertensive diabetic. He suddenly developed swelling of his left leg. Doppler evaluation revealed DVT. So he was started on Clexane 60 mg BD as DVT prophylaxis, and the general physician sent me to rule out if there is any pulmonary embolism. So when I saw this patient, he was having no tachycardia, no hypoxia, no hypotension, ECG echo, no evidence of pulmonary thromboembolism. And he was elderly, 64-year-old, and he had unexplained DVT. So as I have said previously, we searched for malignancy. We sent tumor markers, PSA for prostate malignancy, that was negative. Carcinoembryonic antigen for colon cancer, that was negative. Alpha fetoprotein for liver malignancy, negative. CA19-9 for pancreatic, all negative. So we did CT chest, CT abdomen, and CT pelvis, CT pulmonary angiogram, and CT venography of the lower limb to search what is happening exactly. Are we missing any tumor anywhere, and how the veins of the lower limbs are there? We wanted to see that, and we found that this patient has left common iliac vein appears significantly thinned out, compressed, sandwiched between right common iliac artery and posteriorly by the bridging osteophytes at the level of L4 vertebra, seen as long segment narrowing of left common iliac vein, to consider possibility of May-Thurner syndrome. So this was a case of May-Thurner syndrome. You can see what is May-Thurner syndrome, what happens in that. Here, due to abnormal position of the great veins and great arteries in the pelvis, what happens? The left common iliac vein is compressed due to right iliac artery. You can see here, left common vein which is present posteriorly, it is getting compressed by right iliac artery. In between right iliac artery and the spine, it get compressed. As the vein gets compressed, the stasis happens in the left common iliac vein, and this stasis creates hypercoagulability and DVT develops. So this usually present in young patient, especially in the ladies, and recurrent acute left-sided iliofemoral deep venous thrombosis. 2 to 5% cases of DVT is due to May-Thurner syndrome. Female patient who are using oral contraceptive pills, who are having scoliosis, they usually have they should be how it is diagnosed? It is diagnosed with ultrasound Doppler or CT venography, magnetic resonance venography, or venography with intravascular ultrasound. Management is catheter-based thrombolysis followed by stent placement and subsequent anticoagulation as per DVT protocol. Warfarin is recommended as long-term anticoagulation for this patient. So this was an unusual case. So always we should try to find out what is the reason behind DVT. We had similar case in Apollo Hyderabad recently. A young patient developed DVT, and we found that he is actually having May-Thurner syndrome. And we did stenting to his left common iliac vein to prevent further formation of DVT. That can be catastrophic if he develops pulmonary embolism, and we have put him on anticoagulation with neuroral anticoagulation. One more interesting case I got to treat is that 70-year-old male patient. He was referred to me by a general practitioner after diagnosing that he had developed left lower limb DVT, and he already put patient on Eliquis, and he sent to me for cardiac evaluation. When I saw him in OPD, I realized that his ECG echo is normal, and clinically he is not having tachycardia or hypoxia, and there was no evidence of pulmonary embolism. And I advised them to continue Eliquis as a treatment for his DVT. But again, I was searching what is the cause of DVT. Question regarding malignancy: is there any weight loss? If there are any lumps and bumps in the body, is there any unexplained fever? Is there any loss of appetite? If there is any bleeding from natural orifices? But there was nothing to suggest malignancy. But I noted that patient was walking unusually slow, and there was loss of arm swing on both the arms, and his face was mask like. So I suspected, is this patient having Parkinsonism? He looked 70 years, but his walking is very slow. Doesn't look like this is due to his age. So I asked first. I thought, is it idiopathic Parkinsonism? So I asked him since how long he is having slowness of movement. So attenders told that since only 2 months he is having slowness, and most of the time he is lying on the bed only. So there was no tremor, but his rigidity was more pronounced. Short history of slowness since 2 months, and only an absence of tremor was pointing away from idiopathic Parkinsonism. So in idiopathic Parkinsonism, there will be tremors in unilateral, but he was having no tremor and he was having rigidity more than tremors. So I asked for drug history, and I found that he was actually a patient of schizoaffective disorder, and he was put on antipsychotic. I asked what antipsychotics he is taking. He was on medication called Down 2, and this is the medication risperidone, and risperidone is known to cause drug-induced Parkinsonism. So this patient developed drug-induced Parkinsonism, bradykinesia, and he was on bed most of the times. Due to this, he developed DVT. So I explained the same situation to the attenders, referred back them to the psychiatrist to change his antipsychotic medication to other medication which are not causing drug-induced Parkinsonism, and he was changed the medication to Carispec, which is a newer antipsychotic, and this patient improved and his Parkinsonism resolved, and he is better now. So just I wanted to give a message that whenever you see a patient, just don't write anticoagulation oral and IV. DVT is far more beyond anticoagulation. You have to see the patient in a generalist approach first, then you go to your specialist approach. From finding the problem of patient is important than treating the report of ultrasound, report of Doppler. So I have more slides regarding DVT and pulmonary embolism, and it will take more time. If sir allows, I can continue.
Yeah, at the off chair. Yeah, it's a wonderful summary of the practical clinical cases managed day in and day out by Dr. Sab. Very interesting thing is the HIT, heparin induced. Am I audible, doctor?
Yes, yes, sir. Yes, sir. Yes, sir.
Am I audible?
Yes, sir. Yes, sir. You are audible, sir. Yes, sir.
Okay. It's okay. Speaker. Am I audible, doctor?
Yes, sir. Yes, sir. You are audible, sir.
Yeah, yeah. So, heparin-induced thrombocytopenia is more like an autoimmunity where there are antibodies against the platelets when you give heparin. And instead of the biggest paradox is what is heparin? Heparin is anticoagulant. You can stop that. Yeah. Heparin is anticoagulant. Low platelet count situation also you expect bleeding. Right? In spite of thrombocytopenia, in spite of heparin, what the patient has in HIT, heparin-induced thrombocytopenia, is not a bleeding diathesis. Rather, it is a thrombotic state. So HIT is of two types, HIT type 1 and type 2. And in the HIT type 1, you need not stop the heparin. You can continue. But in HIT type 2, we generally need to stop the heparin. That's a very common experience that we get while using the heparin, and a lot of times small bleeds present. That's a very good case that has been presented. And second is you have shown us the complete florid radiological features of pulmonary embolism classically. One is called Westermarck's sign, and other is called Hampton's hump in pulmonary embolism. So whenever there's a pulmonary embolism, there is a subpleural infarct. So below the pleura, which typically presents like a triangular shadow, as what you can see here, which is called the Hampton's hump. And there will be a focal oligemia of the pulmonary vessels radiologically, which is called as the Westermarck sign. So those two are very classical, and which you are able to see in the radiograph. Then, as rightly said by Dr. Saab, that 2D echo is not most of the times helpful in pulmonary embolism unless there is a significant hemodynamic compromise. So this is one very interesting and important point to learn from the cardiologist, that whenever pulmonary embolism is there, there is a pulmonary hypertension. So what is the difference between systemic circulation and pulmonary circulation? Whenever hypoxia is there, systemic, there is a vasodilation. Whereas in pulmonary circulation, there is a vasoconstriction. That's the reason there's a pulmonary hypertension. So how do we know that there is a pulmonary hypertension when we do 2D echo? What is the parameter? We call it as RVSP. That is right ventricular systolic pressure. So whenever the pressure against which right ventricle need to pump, whenever there's a pulmonary hypertension is there, it need to use more pressure during the systole. So whether it is below 20, 20 to 40, above 40, we call mild, moderate, severe. RVSP is the parameter we need to look for in the 2D echo. So that is a second very interesting point. And third very interesting learning for me, as Dr. Syed said, is orthopedicians are afraid of putting heparin, but orthopedicians are the ones who create the greatest immobility. And that way, because of their timidity to anticoagulate the patient, that's they are one of the etiological factors in creating the DVT in the patients in the post-operative phase. So that is what we need to be very watchful about. And generally we call S1, Q3, T3. S in the lead one, S wave. S is a negative wave. Q3. In the lead 3, the negative wave is Q wave, and T inversion in lead 3. So it is characteristic feature. It is not obvious feature always, right? So typically after becoming a topper in post-graduation, in first year MD, we all used to talk a lot of theory. And slowly we were completely humbled by the patients every day. So we need to be happy with sinus tachycardia. So why pulmonary hypertension lead to sinus tachycardia? So when there's a pulmonary hypertension, the right ventricle is unable to pump adequately into the pulmonary artery, right? So that will make the heart go into excessive rate, sinus tachycardia, which is enough to consider a possibility of pulmonary embolism. Lastly, I can never forget the nightmare I had in the pulmonary embolism. Dr. Syed gave me an opportunity to recall. I was a second year postgraduate. So that time the patient had a severe pleuritic pain. So when there is a pleuritic pain, we took a radiograph to look for any pneumonia or any pulmonary pathology. Then we found effusion. So the costodiaphragmatic recesses are all full. So when there is an effusion, we did a tap, and it turned out to be a bloody tap. So bloody tap, hemorrhagic pleural effusion, because of the pulmonary embolism leading to infarct of the lung, lead to bloody tap. So when there is a bloody tap, what is the option you have to, in a patient of pulmonary embolism with a pulmonary infarct? We need to thrombolize. But to thrombolize a patient who had a hemorrhagic effusion is a nightmare. But there is no other option because there is a severe pulmonary hypertension in the patient. So thrombolized. So when we thrombolized, the hemorrhage in the pleural effusion become almost like a sea. So I could not know what to do with that patient except to drain that sea of blood coming out of the pleural effusion by placing an intercostal drainage. Ultimately, patient survived. But that is one bloody night I spent with pulmonary embolism with hemorrhagic pleural effusion, but managing with thrombolysis, which is the no other option available in a patient. So thank you so much, Dr. Syed. wonderful clinicians like you who are passionate to uh, teach and learn from every case are the need of the hour for many residents like us to learn. So thank you
Thanks a
once more.
lot, sir. Thanks a lot, sir. Thank you, sir. Thank you.
So every Friday,
Hearing this word from a personality like you is, I can't explain in words, sir. Thanks a lot, sir.
sure. So every week on Friday evening, 4 to 5, we have a clinical discussion session, and I love to see you every week with one very nice case from cardiology, and
Sure,
that
sir.
will be a true honor. Thank you.
Sure, sir. Sure.
Thank you
Thanks a
all
lot.
for attending. Yeah.
Thank you, sir.